We have a great lineup here for you, and we're all queued up and ready to go. So again, if you have any questions as to what's going on, we saw that there was a great chat feature going on down below. If there's anything that you have questions about in our presentation, please feel free to use that feature down below. That's super helpful for all of us, so thank you. Without further ado, I'd like to go on ahead and introduce our very first speaker. Dr. Philip Seo is the director of Johns Hopkins Vasculitis Center. He's the associate professor of medicine there. Dr. Seo is an associate professor in the Division of Rheumatology. A graduate of Harvard College and the College of Physicians and Surgeons at Columbia University, Dr. Seo completed his internal medicine training as a member of the Osler Medical Service at the Johns Hopkins Hospital. Since then, he has worked at Johns Hopkins in several capacities, including as a hospitalist at Johns Hopkins Bayview Medical Center and as an assistant chief of service of the Department of Medicine at Johns Hopkins Hospital before joining the Division of Rheumatology. Dr. Seo is the director of the Johns Hopkins Vasculitis Center and director of the Johns Hopkins Rheumatology Fellowship Program. His clinical interests lie in the assessment and treatment of patients with systemic vasculitis, in particular, ANCA-associated vasculitides, which include granulomatosis with polyangiitis, microscopic polyangiitis, and EGPA. Welcome, Dr. Seo.
Thank you very much for that very kind and completely unnecessary introduction. And just to put everything in perspective, I decided I'm going to share a story with you. So years ago, my mom called me and said, could I ask you a question? And I said, sure, Mom, what? And she said, do you know a rheumatologist? I'm like, yeah, Mom, I'm a rheumatologist. And then she laughed. And she said, no, seriously, do you know a rheumatologist? So don't be too impressed by all the titles. As a colleague of mine at Hopkins says, it's easier for them to give you a title than it is for them to give you a raise. So I want to thank all of you for giving me this opportunity to speak to all of you this morning. I'm here to talk to you about emerging therapies for vasculitis. And I had forgotten until recently that Joyce Coleman renamed it the Vasculitis Minions Talk. And why it's called the Vasculitis Minions Talk will be obvious to you in just a little bit. So in this talk, what I want to do is I want to talk about some of the newer therapies that are emerging for the treatment of systemic vasculitis, some of which are already part of the standard of care and some of which are just being vetted now and may become standard in future years. So in order to do that, we're going to talk a little bit about how immunosuppression works. And then we're going to talk about the different strategies that are used by these new immunosuppressive therapies. There are three main strategies. The first one is selective immune cell depletion. The second one is cytokine-based strategies. And the third is inhibition of immune targeting. And I realize that it's early and it basically sounds like everything I said was in Greek. And I promise you that towards the end of this talk, everything will start to make sense. So let's start by talking about how immunosuppression works. But another way to think about it is what the minions taught me about my immune system. So the first thing to get out of the way is when I'm saying minions, I don't mean minion with a lowercase m. I'm talking about minions with a capital M, the yellow guys on the screen right now, who came out in a movie in 2015. Now, if you have the great misfortune of never having seen this movie, I highly recommend that you abduct a kid or two so that you have an excuse to watch it, because it's easily one of the best movies that I've seen in my life. And I like using them to teach people about immunology. So the first thing we need to do is discuss about how autoimmune disease occurs. And this is kind of complicated in concept, and I know it's going to take a little while to soak in, but I want you to understand that I'm going through all this information for a reason, and that as you start thinking about it and it starts to soak in, it'll start to make sense. So this is basically what happens. So you got to think of autoimmune disease like your immune system is a toddler who's starting to have a fit. Like all of a sudden he's crying, he's screaming, completely inconsolable, pulling things off the shelf, like completely having a spasm. And the object of immunosuppressive therapies is basically to calm that toddler down so he goes back to sleep. So if you're like most people, you've probably Googled about vasculitis and you know that your immune system is comprised of various types of cells. So there are B cells and T cells and neutrophils. If you have EGPA, eosinophils are important, but there's a whole bunch of immune cells, some of which aren't even listed on this slide. I'm going to tell you, forget about all about that. What you really need to know about your immune system is your immune system basically has three major functions. Your white blood cells need to know how to fight because they need to fight off infection. They need to be able to talk to each other so they can collaborate. And they need to know when to give up. And if you think about people who have autoimmune disease like vasculitis, basically it ends up being a dysfunction in one of these three major functions of white blood cells. And the reason why that's so great is because since we know this, we can actually target individual components of the immune system in order to make some people better. Now, I realize this sounds like a kind of a crazy science fiction sort of advanced way to think about these diseases, but it's actually really common. And believe it or not, you actually know a lot about this already, partially because of this guy. This is Phil Mickelson, who for many years has been the official spokesperson for Enbrel, which is one of these newer therapies that we're talking about. And this is another one. This is also an immune-based strategy. And you can tell this is a good drug because you can see this woman very happily starting her day of work. She has this large purse. She's heading outside, sunshine streaming through the windows, and all thanks to this particular drug. Now, obviously, this is an advertising strategy because just because you're taking this particular medication doesn't mean that you're going to be this happy couple walking down the beach. But it's a nice image. And certainly they've been advertising very heavily. So if you're up at 3 o'clock in the morning, you've easily seen one of these commercials. I will point out as an aside, this particular ad is actually an ad parody. And it just emphasizes the fact there's a downside to everything. And I'm happy to talk about some of those downsides at the break. So strategy number one, which is selective inflammatory cell depletion. But another way to think about this is how not to hurt your friends. Okay, this is not going to be a political discussion. All I want to say is even if you're a fan of the president, you have to admit that he would be better off if sometimes he just knew when to stop. And that's the problem that occurs in people who've got autoimmune disease. Basically, what the problem is that you have a hyperactive immune system. So the problem isn't that your immune system turns on. That's good. That's how you fight off disease. The problem is that your immune system doesn't know when to stop fighting. And because your immune system never turns off, this gradually leads to autoimmune disease like vasculitis. So let's talk about conventional immunosuppression. I think of these drugs as like the Gen X generation of immunosuppression. They may be a little bit older, but they get the job done. And if you've got a diagnosis of vasculitis, chances are you're friends with at least one of these drugs. So I thought it'd be useful to talk about how these drugs work. They're like weed killer. So if you think about it, weed killer is one of those things that is probably kind of a little bit toxic to everything. It's not something that you would put in a glass and just drink. But if you use it exactly right, it will hurt the weeds before it hurts the begonias or the roses. And our conventional immunosuppressor drugs like azathioprine or methotrexate work just like that. Because the cells that are most sensitive to these drugs are the immune cells that are hyperactive. And by using them in exactly the right way, at the right dose and the right timing, we can affect the immune cells before we affect any other cells. And that's the reason why these drugs have been so good to people with vasculitis for so many years. Now, if you think about it from an intellectual standpoint, though, that's an awfully primitive way to treat anything. Because I just told you, it affects all the cells all at once. And some of the side effects, frankly, of these drugs are from people where some of the good cells are affected a little bit earlier or a little bit more seriously than we would ideally want. So if you think about it, wouldn't it be great if we could take advantage of the fact that your immune system is comprised of all these different cells and just target the cells that are causing the problem and leave the rest of your immune system alone? And in fact, that's exactly what we do. So I'll give you an example. It turns out that B cells are really important to two particular diagnoses, namely granulomatosis with polyangiitis and microscopic polyangiitis. And we have a drug called rituximab that actually gets rid of B cells. And we find that rituximab is incredibly effective at treating these diagnoses, and probably even more effective than any other drug I currently have. I'll give you another example. Eosinophils are very important for a diagnosis called eosinophilic granulomatosis with polyangiitis, also known as the Churg-Strauss syndrome. And we have drugs that can actually eliminate eosinophils and leave the rest of your immune system alone. Let's talk a little bit about that. So Mepolizumab is a monoclonal antibody directed against interleukin 5. So what the hell does that mean? Okay, so remember the first step is eosinophils are the immune cell that cause EGPA. That's why it's called EGPA, eosinophilic granulomatosis with polyangiitis. Interleukin 5 is like fertilizer for eosinophils. They make the eosinophils grow faster and they make them more alive than they would be without the interleukin 5. So the theory is if you get rid of the interleukin 5, you can get rid of the eosinophils. And if you don't have the eosinophils, then you don't have a disease. This was actually looked at by a very large clinical trial looking at patients who had EGPA, and they found that when you treat patients with mepolizumab, that the patients with EGPA are more likely to get into remission, and they're more likely to stay in remission than people who got standard therapies with drugs like methotrexate and azathioprine. And this has completely changed the way that we treat patients with EGPA. So let's sum up. So remember that conventional immunosuppression is kind of a non-specific strategy for treating disease. It affects all the cells all at once, and we just take advantage of the fact that it seems to affect immune cells first. The newer drugs attack only parts of your immune system, but they leave the rest of the immune system intact. And you can see sort of intuitively why that's such a tempting strategy, because most of your immune system is left alone to do its job. This strategy has been incredibly effective for ANCA-associated vasculitis, meaning GPA, MPA, and EGPA. And we actually think that the strategy will work for other diagnoses as well. And we already have the drugs ready to go because they've been developed in other fields for other diagnoses. And we're just trying to figure out now whether they might work for vasculitis as well. All right, so that was the first strategy. That was selective immune cell depletion. The second strategy is cytokine-based strategies. But another way to think about this is how to keep your immune system from ganging up on you. So the first thing to remember is one angry immune cell is not a problem. By itself, no matter what that cell is, no matter how angry that cell is, it can't cause that much damage. It's just one cell. The problem is that these angry immune cells, they start to talk to each other. And once they find a target that they're really interested in, they start releasing signals to get other immune cells to come join the party. Now, those signals are called cytokines, and these cytokines are responsible for keeping your immune system hyperactive and excited. So the first cytokine I want to talk about is something called interleukin 6, which has two major functions. The first function is it stimulates the production of stuff to fight off infection, like new cells and new proteins. And the second is that it keeps the immune system from turning off. Now, interleukin 6 is really important for fighting off infection, and it's also involved in people who've got cancer, but it also turns out that it's important for some types of vasculitis, and in particular for a vasculitis called giant cell arteritis. So what we know about giant cell arteritis is that high levels of the cytokine, interleukin 6, might actually cause giant cell arteritis. And that this particular drug called Tocilzumab effectively gets rid of interleukin 6. So the theory is if you get rid of interleukin 6, you can get rid of the disease. So there was actually a clinical trial that demonstrated this called GIACTA. And it demonstrated that when you take patients with giant cell arteritis and you give them this drug that gets rid of interleukin 6, they're a lot less likely to flare as you taper their steroids. And they may even come off steroids a lot faster than people who get standard therapy. The other cytokine I want to talk about is GM-CSF. Now, GM-CSF stands for granulocyte macrophage colony stimulating factor. And you should just forget that right now because no one ever spells it out. It's kind of like Lady Gaga. No one really calls her by her real name. She's just Lady Gaga. In the same way, this particular cytokine is always called GM-CSF. And when it was first identified, all we knew about it was it causes your body to produce new white blood cells. And that by itself might not be a problem. But we later figured out that it takes old white blood cells and makes them live longer. It makes them hyperactive. And it tells them where to go. So you can imagine if this particular cytokine showed up in the wrong place, that this could easily cause a vasculitis. Now there's this new drug called Mepolizumab, which is a monoclonal antibody that inhibits the GM-CSF receptor. And you can tell this is an important drug because I actually had to practice saying this particular drug name in order to give this talk. So there's a reason for this. And the reason is that it actually ends up being one of the more exciting therapies out there for the treatment of giant cell arteritis. So the way you want to think about this drug is if you think about GM-CSF like a key, then the GM-CSF receptor is like a lock. And this particular drug is like sticking chewing gum into the lock. So it's not like the key's gone away. It just means the key can't do what it's trying to do. All right, so in a mouse model of giant cell arteritis, what we know is that GM-CSF is found in elevated levels in inflamed arteries. And if you get rid of GM-CSF, that the inflammation seems to go away. And that's fine if you treat mice. But for the rest of us who treat people, what we found out was if you give people with giant cell arteritis this particular drug, it seems to decrease their relapses and it increases their rate of remission when they have a diagnosis of giant cell arteritis. Now, this is hot off the presses. This is what they call a phase 2 trial, which means it's a small trial just to see if the drug does anything at all. So whether or not this drug will actually make it to prime time, we're not sure. But in theory, it's really exciting, and it's really great to know that we're going to have even more options for people with giant cell arteritis than we have already. All right, so let's sum up. Remember that one angry cell by itself is not a problem. It really takes hundreds of these hyperexcited cells to cause disease. And the problem occurs when the immune cells start to talk to each other because they get each other excited and they keep each other from turning off. We now have drugs that interrupt that conversation. So when these cells can't stimulate each other, they gradually turn themselves off by themselves. This particular strategy has been very successful for the treatment of giant cell arteritis, but we think it actually also works for other forms of vasculitis, and we're just in the process of proving that. All right, so that was the second strategy. The last strategy is inhibition of immune targeting. Or they can't hurt you if they can't find you. So remember that if you have all these angry, hyperexcited cells, it's not a problem if the cells don't know where to go. So you picture all these angry cells sort of floating around this parking lot, and if they're all just floating around and they don't know where they're headed, then it doesn't really cause an issue. So one way that immune cells know where to go is with antibodies. Now, antibodies are the way that your body tags things that it doesn't want, and it's trying to get rid of. You can think of it like the RFID tag that they use in the airports in order to tag your luggage, or with the barcodes that FedEx uses in order to track your packages. It's the way that your immune system tracks things. This is a great system to get rid of bugs. So if your body has a bacteria or a virus that doesn't belong there, this is an incredibly efficient system. But you can imagine that if those antibodies accidentally get attached to a blood vessel, this could cause a serious problem. So the theory is if you can get rid of these particular antibodies, you can get rid of the vasculitis. I'm going to say something offensive, and I'm going to ask for your forgiveness ahead of time. Men are dumb. And so if you're a guy, this particular technique is going to make perfect sense because it's basically plumbing. Plasmapheresis, also known as plasma exchange, is where they suck out your blood, literally. and they pull off the antibodies that they think are causing the inflammation, and then they give your blood back to you. It's kind of like a washing machine for your blood. And if you've had vasculitis for a while and you've never heard about it, it's because this is exactly as crazy as it sounds. I mean, we're literally taking your blood and cleaning it and giving it back to you. So you can imagine this is only a strategy that we want to use if we feel like we don't have any options. Now, this strategy used to be pretty standard for people who have severe forms of ANCA-associated vasculitis, meaning GPA and MPA. And some of you may know that there was a large clinical trial recently that showed it probably doesn't work as well as we thought it did. Now, from my standpoint, that's great news. And it's because one of the reasons why we do clinical trials is to figure out what we shouldn't be doing to patients. Because I would never want to put a patient through plasma exchange if I didn't think there was a significant chance that they would do better. Now, that doesn't mean that plasma exchange isn't used for any patients at all. And in fact, we still think it works well for a cryoglobulinemic vasculitis, especially for very sick patients. And it may also work for other patients with vasculitis as well. There's another signpost I want to talk about, which is called C5a. So C5a is part of the complement cascade. And again, don't worry about that so much. All you should know is that C5a is just another tag that your immune system uses in order to target certain things it's trying to get rid of, just like an antibody. So there's this new drug called Avacopan, and it's kind of like Teflon for your blood vessels. When you take this particular drug, C5a can't stick to your blood vessels. So the idea is if that your immune system doesn't know it's supposed to attack your blood vessels, it can't cause vasculitis. There's actually a study that recently was presented publicly in a European meeting just a few months ago that demonstrated that if you have either GPA or MPA and you take this drug, you actually do a lot better than you do if you just get standard therapies. And in fact, the really fascinating thing about this particular drug is it works even if you don't take steroids. I'll say that again. This drug works without steroids. That's amazing. And I'm really hoping that this drug will turn out to be a great thing for everyone with vasculitis. I want to talk about another signpost that your immune system uses, namely interleukin-13. So remember I told you before that eosinophils are the cause of EGPA? Interleukin-13 is involved with eosinophil trafficking. What that means is interleukin-13 is how your body signals your eosinophils and tells them where to go. So there's this drug called Dupilumab, which blocks the effects of interleukin-13. So your body still produces a lot of eosinophils, but they just don't know where they're going. So they just hang out in your bloodstream, not really doing anything. So the idea is if your eosinophils can't find their target, they can't cause disease. Now, we already know that this drug works really well for other diagnoses that are mediated by eosinophils, like people who've got really bad sinusitis, for example, or people with bad allergic skin reactions like eczema. Dupilumab is actually a great drug. We think it also might work for patients with EGPA, but that's something that's still in progress right now, so I can't recommend it to anyone with EGPA at this moment. So let's sum up. Remember that your body uses various tags like antibodies and proteins to figure out what to attack. When those tags get attached to a blood vessel, you develop a vasculitis. There are now new methods of interfering with these tags to prevent vasculitis. Plasmapheresis, for example, which sucks the tags off, and drugs like Avacopan, which prevent the tags from sticking. The real advantage of these strategies, in particular Avacopan, is these may be the first agents ever to work to treat vasculitis without the use of steroids. So just a final thought. If you are younger than me, you don't know who this guy is, but this guy's Yogi Berra, who's probably more famous for saying crazy things than he was ever as a member of the Yankees. For example, he said once, I didn't really say all the things that I said. But one of the quotes that he said that I really like is, it's hard to make predictions, especially about the future. So I always keep that in mind when I think about these newer therapies for vasculitis, and I'm going to give you one last example of that. This is Tina Fey. All of you know that. No one knows who this guy is. And the only reason why I know who this guy is because there was an article in the Rolling Stone that listed all 141 cast members ever to be on SNL and ranked them from best to worst. So some of the treatments I've been talking about today, they're going to end up being the Tina Feys of the vasculitis world. And some of them, unfortunately, might turn out to this guy. And it's really hard to predict which ones are still going to be in use in the next 5 or 10 years. All I can say is it's really exciting to be in this field, especially right now when it's changing so quickly. That's all I had to say. I just wanted to give you my acknowledgments, which is I want to thank all the members of the Vasculitis Center at Hopkins, past and present. I want to give special thanks to the Darwin James Liao family who supported our work. And that's all I've got. Thanks very much.
All right. Well, thank you so very much, Dr. Seo. We appreciate your presentation. It was very informative and it put it in kind of an easy to understand format. So thank you so very, very much for your contributions. Thank you.
Absolutely.